A very warm welcome to each of you to this webinar, linking live from many different parts of the world and listening to the post-event recording. Good morning, good day, and good evening, wherever you may be. A special welcome to our esteemed panel of experts today, whom I would shortly get to introduce. My name is Sham Mudli. I'm a community pharmacist, as you can see, practicing in the very beautiful city of Durban in South Africa. I am the deputy chair of the Independent Community Pharmacy Association, a member of the Pharmaceutical Society of South Africa, an affiliate of FIP, and an EXCO member of FIP Community Pharmacy Section. FIP's vision is a world where everyone benefits from access to safe, effective, quality and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, science, and education. We are pleased to be delivering this event, which is actually episode number 14 of our program of 17 events on self-care under the theme of shaping the future of self-care through pharmacy. As a healthcare providers, pharmacists have an important role to play in supporting self-care. This program is composed of 8 episodes that refocuses on accelerating universal health coverage for all by establishing self-care through community pharmacy. Additionally, a further 9 episodes focuses on self-care support for our community pharmacy team. FIP's announcement and just the housekeeping rules for this morning is that this webinar is being recorded and live streamed via YouTube. The recording will be available on our website under events.fip.org. You may ask questions using the question box provided. You are welcome to provide feedback on webinars@fip.org. And we encourage you to become a member of FIP, and you can access the membership details from membership registration. Next slide. So without our sponsors, we are unable to provide these types of events. Our sponsor today is Ricket, and we thank them for their support for this project via an educational grant. The views expressed, nevertheless, of the speakers are not necessarily the views of Ricket, but their own. Next. So our agenda for today is we're going to move straight on to Professor Reddy, who's the Public Health Foundation, is from the Public Health Foundation of India. The next topic will be public and patients' perspective on self-care's contribution to universal health coverage. And we have Jacqueline Bowman-Bussato, who is from the Patient Foundation in Belgium. We then move on to a localized self-care delivery system, a case study from the UK, and this will be presented by Dave Burrows from Damibu. And then we move on to a panel discussion with question and answers, and then do a summary at the end and hopefully finish on time. Next slide. So the learning objectives for today is to explain the extent to which self-care is embedded in healthcare systems, discuss cultural approaches to enabling self-care as part of the universal health coverage, such as healthy lifestyle, list healthcare systems and patients' public needs for enabling self-care, and discuss the contribution of localized self-care delivery to universal health coverage. Okay. So as I said, our first speaker is Professor K. Srinath Reddy, and Prof. Reddy is from the Public Health Foundation of India. He has a very extensive CV, but to summarize, is formerly the head of the Department of Cardiology at All India Institute of Medical Science in New Delhi. He's been appointed as the first Bernard Lowen Visiting Professor of Cardiovascular Health at Harvard School of Public Health, and he served there from 2009 to 2013. And at present, he serves as the adjunct professor of epidemiology at Harvard University. And this he started in 2014 and is present until 2023. I'm going to hand over to Prof. Reddy. Before I do, just to indicate that Prof. Reddy does not need a slide pack presentation, and he will talk to you live. Over to you, Prof. Reddy, and welcome.
Thank you very much. It's a pleasure to be part of this event, and greetings of the day to all the people who are listening in from whichever time zone they are actually participating from. I've been asked to speak about the public health perspectives. Therefore, I would need to start by defining what public health means to me. I believe that public health identifies and influences the determinants of health at the population level to impact upon health at the individual level. Therefore, whether it is policies, systems, programs, services, and community engagement, public health encompasses it all, including the nature of how hospital services are configured, patient services are facilitated, and even access to medicines of quality assured drugs is possible. So starting with that point, let me talk about the concept of how universal health coverage, which is going to be one of the most important objectives of the Sustainable Development Goals, can accommodate and can benefit from self-care. Clearly, we are talking about universal health coverage or universal health care covering all types of health services which are needed by people across their life course, from health promotion to disease prevention, to diagnostic services, to therapeutic care, to rehabilitation and palliation. We also recognize that there are three dimensions of universal health coverage. That is population coverage, what proportion of people are covered by the services with the widest possible access. Second is service coverage. How are the services being provided in terms of the nature of the service components that are actually available under the program, and also the quality of the services being provided. And finally, cost coverage. How affordable is it? How does it prevent catastrophic health expenditure and out-of-pocket expenditure and does not push people into poverty? So I would like to apply the principles of what we call health promotion in this whole area of self-care, because self-care is absolutely important in promoting the abilities of people, particularly as individuals, but also as groups, in order to try and provide care even when a healthcare provider is not available or is not needed at all points of time. In terms of health promotion, these principles are that a person must be able to say, I know, that is, with adequate access to information. The person should be able to say, I wish to, that is, having adequate motivation. Thirdly, the person should be able to say, I can, that means have the requisite skills and a sense of competence. Then, in addition to that, the person should be able to say, I will be able to, that means I have enough of a supportive environment. There is nothing impeding my action if I choose to, on the basis of my knowledge and motivation. And finally, that I will be assisted and guided when needed through supportive health services and supportive social services. And we recognize this as absolutely important. Whatever we are really looking at, multiple dimensions, we are seeing how whether it is the creation of smoke-free public places so that people are not assaulted by secondhand smoke, or having pedestrian pathways, cycling lanes, the price of healthy foods, and of course, the price and quality of medicines as well. So all of these are essentially being accommodated in this whole concept. Then across the healthcare spectrum, as I said, right from health promotion to palliation, we need to look at all of the services. And if you look at healthy living habits as one of the foundational elements of not only public health in preventing disease and promoting better health, but also ensuring that the effects of disease are mitigated and the effects of therapies are enhanced, then certainly we need to really look at elements from hygiene at a personal level to sleep, the sleeping habits, the quality of diet, to the extent and nature of exercise, avoidance of addictions, which can undermine the best of therapies, whether you're actually going to be practicing stress management, whether it is yoga or music, whatever way you are able to relieve your stress. All of these are important in terms of promotion of healthy living habits, which are absolutely important for a successful therapy also to be provided to the person. Then comes the whole area of self-diagnosis and self-referral, right from self-examination of breast for lumps to diagnosis of diabetes by urine testing, even on suspecting that one is getting diabetes because of polyuria, nocturia, that is excessive urine during the 24 hours or excessive passage of urine in the night, a variety of symptoms. Diagnosing chest pain, whether it is coronary disease or not, whether it's angina or not, or a heart attack or not, and seeking help immediately. Even being able to take an aspirin straight away, even before contacting the doctor for a suspected heart attack. All of these are important elements of self-diagnosis, self-referral, and the initiation of self-care. Then when we are really talking about other elements like a mole changing shape, suspecting that it could be a it could be a melanoma, or lumps anywhere, possible cancer, change in bowel habits, possible colonic cancer, self-testing of urine and blood, not just for pregnancy, but for diabetes and many other conditions now. All of these are becoming absolutely important. Then you also recognize that self-monitoring and treatment is also important in terms of medicines. Not only understanding what medicines are being given, when they need to be taken, what are the precautions, what are the side effects, but even in terms of getting the replenishments without necessarily having a break in the treatment so that the adherence is perfect to the extent possible in order to ensure that you benefit from the treatment, and even how to access an e-pharmacy intelligently. What are the side effects of medicines? What are the unproven drugs that you must keep away from? What are the unproven vaccines that you must keep away from? Or what are the possible side effects, minimal side effects that you may expect, or severe side effects that you may expect, so that you may take care? How do you ensure that you are not prey to false advertising of various untested or fake medicines? So those are important elements that you need to look at as well. Then comes the whole area of rehabilitation and exercise, whole area of rehabilitation through diet, through exercise, etc. All of that, again, while you may be guided by a professional, you may have to practice most of it on your own, and that is absolutely important in terms of self-care as well. But then, apart from that, we must understand that the whole paradigm of medical care is shifting from a prescriptive, paternalistic model of care where the physician dominates and the patient, who is relatively uninformed, is a very obedient follower. We now recognize that we are trying to bridge the information asymmetry and trying to make the person who is receiving the care also a partner or a part in participatory care. So reducing the asymmetry is absolutely critical. And so that we have informed decision making with the person and the family, if possible, also becoming quite aware of which care to take and why it is being given. Then, of course, when we are dealing with insurance systems, we must have insurance literacy as well as to how best we actually use the insurance system to the advantage of the patient rather than to the detriment of the patient. What is the insurance literacy? How do we understand how to file claims? What are the entitlements? What is covered? What is not covered, etc. Then, of course, it's not just the individual. We recognize that even groups are important in terms of families, in terms of patient support groups. All of them are actually also are a part of self-care because we are all part of a community, we are part of a family, and all of that actually comes into the ambit of self-care. Then, particularly, for example, when you look at a condition like mental health, where there are mental health disorders which require a lot of family support, which require a lot of community support, apart from self-care too, at the individual level, we do require a lot of this to happen. And then in terms of persons with disabilities, again, there is a requirement of a lot of support, not only in terms of a person gaining a lot of assurance to look after himself or herself, but when required, being supported by the family as well as other members of the community. So we recognize that all of these are absolutely critical. But at the level of the community level, we also recognize that in public health, there are many other conditions in which the community must act together in order to protect and promote health, so that the objectives of even well-intended treatment are not undermined. Like, for example, sanitation, trying to get the pollution levels low in air, water, and to ensure that there are smoke-free public places, that there is road safety, that there are safe and pleasurable recreational community spaces, that there are protected cycling lanes, bicycle paths. All of these are important in terms of self-care at the level of the community, because if they are flawed, they ultimately impact upon the health of the individual. So the self-care also has to actually be enhanced by community participation at a much larger level. So I believe these are absolutely important elements that will actually advance the objectives of effective health coverage, and particularly fit in very well with the concept of universal health coverage, which extends across the life course and covers all the dimensions of health and not merely the provision of health insurance. So we do recognize that whether we are discussing in terms of access, affordability, quality of care, we can actually promote health equity in all dimensions by advancing self-care, particularly under the umbrella of universal health coverage, which is now a very important target of the Sustainable Development Goals of the United Nations. Thank you very much.
Thank you, Prof. Reddy. Your involvement as an advisor to government at various provinces certainly comes through your presentation today, and I'm sure there will be many questions that will be raised by the audience today. It gives me great pleasure then to introduce our next speaker for today, and that's Jacqueline Bowman-Husato. She's the co-founder of the Belgium private foundation, Pate Adiposi. I hope I said that right. She's worked for the past 23 years towards transforming health ecosystems from policy to reality, very passionate about citizen care, a pioneer of multi-stakeholder coalitions that's building for the societal impact. She's also a multi-linguist with French, a little bit of Dutch and English, and a previous citizen of Guyana, and currently a British national. Jacqueline, welcome to the floor.
Thank you so much, Sham. I would say, as I've been saying to everybody as well, I'm now a Brexit minted Belgian. So I now have yet another nationality to my name. Okay, so I'm really, really pleased to be speaking with you all today on the topic of public and patients, but we'll come to that, perspectives on self-care's contribution to universal health coverage. I want, however, to firstly, I first, however, want to be sure that you understand that I'm coming from a slightly different perspective than one might at first expect, because as I'll talk to you a bit further down this intervention, I am, I would say, a novelty, because I am a patient expert and a health consumer expert, as you can see from my disclaimer and professional affiliations. Next slide, please. As we go through, please put your questions into the Q&A, as well as please tweet towards Adipositas BE, which is the Twitter account for the Belgian Foundation for the Belgian Foundation for the Rights of People Living with Obesity, who I'm representing today. So before I actually get into the full answer to the question, I think it's also important to understand a little bit about the foundation, because that actually impacts our general approach to patient partners, patient rights, and generally for people living with a particular chronic disease, chronic condition. So we're actually quite new. We founded in February of this year, with the big aim to be the authoritative voice for the rights of people living with obesity in Belgium. Now, that's really important for us because in Belgium, there are 49% of a population of 11 million, and that's measuring conservatively only through BMI, that are actually living with pre-obesity or obesity. So myself and my colleague Petronella Jurison decided we need to do something about this. Next slide, please. And so actually we honed in on 3 key elements, one of which is extremely relevant for the set of talks that we're engaging in today. And the first thing for us was, and remains, recognition of obesity as a chronic disease as per the actual definition and scope of obesity set out by the WHO. Secondly, transformation of the Belgian policy and regulatory framework to ensure that obesity patients can make, as our previous colleague mentioned, informed choices and have affordable access to the treatment needed. And in terms of obesity, that means mental as well as physical. Then finally, and a very big pillar, is to make sure that we're educating all stakeholders, not least policymakers and fellow professionals as yourself, as well as people like myself, so people living with obesity, as to the holistic elements of the biological disease and the various ways in which it can be managed, from prevention right through to self-management, which is part of the self-care continuum throughout the life cycle. Next slide, please. So in that context, we really, when I was asked to come and speak with you, I was so excited about this because community pharmacists are the backbone of so many different communities. And for me, it was really the question of, should we consider community pharmacists contributors, or actually, which I would put my hand up to, the central glue to achieving universal health coverage? And what is the role for you from a health consumer perspective? Next slide, please. So let's kick off with some assumptions, and I'll put this up front. Please do not assume. Next slide, please. Do not assume that because there's a formal definition and or a formal political will, that these will actually be embedded in the law. So from a health consumer perspective, particularly related to self-care, we are actually very concerned that we see a lot of interest in providing on paper various rights, but actually, are we capable of taking up those rights? Are we capable of making partnership in our own healthcare a reality? Simple answer, not yet, and certainly not the case in Europe, and certainly not the case in Belgium as we sit here. And definitely not the case currently for people living with obesity. So I go back to the basics of the definition of self-care, which I'm sure you've all seen already and heard. And the words that I want to pick out here, as per my previous colleague, is the ability of individuals and families to actually maintain health, cope with illness and disability with or without the support of a healthcare provider. And also that this definition includes, yes, health promotion, but also disease prevention and control. And this is really key because under normal circumstances, or should we say, the tradition is only to talk about self-care in terms of basically self-promotion, and at best, what kind of self-medication can we get from the community pharmacist? This is a misconception, I would say, by all stakeholders, because you as community pharmacist, and I'll talk about your role any second now, but you as a community pharmacist are there, and actually our first point of and our main point of interaction for the majority of the time that we're managing our chronic conditions and diseases. And that takes me to the second assumption. So the definition of universal health coverage means that all individuals and communities receive health services we actually need, not what we're being told that we need, but what we really need, that is affordable, and that also includes the full spectrum of essential quality health services, again, along the full continuum. Next slide, please. And here I come to the elephant in the room, which is that we're assuming on the whole that only talking about self-care in terms of health promotion and at best primary prevention will actually impact on the vast majority of people. Well, the news isn't that good, because according to the Global Burden of Disease study from which was a Lancet commission, 1 in 20 people worldwide, so 4.3% only, have no health problems. Only 4.3%. So when we're only talking about self-care in terms of promotion and prevention, what about the other 96.7%? 1/3 of whom, 1/3 of the world's population, so that's 2.3 billion more now, because that was in 2013, reported or are reported as experiencing more than 5 ailments. That is a massive marketplace for pharmacists. That is a massive opportunity to actually go beyond primary prevention discourse and actually start achieving the access to health and universal health coverage as per the SDGs. Next slide, please. So, as I said, I am an expert health consumer. Why? Actually, apart from my day jobs that you've seen, I'm also a bariatric patient. So I had bariatric surgery just over 5 years ago. And to be clear, that is not weight loss surgery. That is pure and simple metabolic surgery. My entire metabolism, my metabolic system has been swapped around. And I also live with autoimmune Hashimoto's, which manifests as hypothyroidism. So what that means is that I spend my entire life managing, and a few other chronic conditions, I spend my life actually managing and self-managing a lot of my health. And that would be the same as we saw in the previous slide. But, and a very big but, I'm also someone who is hiding in plain sight. So when I go into my pharmacist, as do a lot of people who maybe have, in my case, hidden obesity, be it visceral obesity or the treatment is working at that particular point in time, but we're still managing because you can't the adipose tissue, which is acting abnormally, which is functioning abnormally, will not disappear. You can shrink it, but it will not evaporate, which means that you're managing that medical condition for life. Next click, please. So what that means is that when I go into my pharmacist, next click, please, and anybody else who happens to be living with obesity, and that's 49% conservatively in Belgium and almost 60% across Europe, what that means is that we're going in with our day-to-day lives. We're not going in labeled as a patient necessarily. We're also not going in to see the pharmacist or access those services, knowing exactly what our disease progression is about. And here, I would say that we're also probably not realizing, along with the rest, unless you're me, that the European Commission actually categorized obesity as a chronic disease earlier on this year. So what that means is that under normal circumstances, we should be accessing the NCD framework. We should be accessing NCD national plans, which should be including how we self-manage. Next slide, please. But in reality, what I have to do every single day, I'm now allergic to some of this, but at the time it was going well, I actually have to think about my scheduling. Now, under normal circumstances, and again, the previous speaker talked about diet and exercise. To put it bluntly, that has almost 0% of managing the disease of obesity. And what I actually focus on, and there's lots of research behind this, is brain clarity, hydration, more hydration, even more hydration, 20 to 30 grams of protein per meal to make sure that actually my muscle mass and my brain clarity is going in the right direction, and more hydration, because by the end of each day, I've got to consume, because of bariatrics, 100 grams of pure protein. And on average, there's 20 grams per 100 grams of HEMA protein. In addition to that, and this is very important for the community pharmacist, I don't have it in front of me, but I could show you my pill box. It's big, and I have to be organized in scheduling all of these different pills. And that's for every single bariatric patient out there. So what we're faced with is actually a reliance on our community pharmacists who are dispensing, in effect, both RX, because of bariatric surgery and anything else that I'm wandering through life with, as well as all of those nutritional supplements and dietary supplements, which are compulsory for people who've had bariatric surgery, but which, certainly in Belgium, were not actually being taken into account until very recently when we went to see our doctors. Next slide, please. So what does that actually mean in the end? Well, here we come on to bridges. Next slide, please. And more specifically, the importance of building bridges for mutual empowerment. So in the previous speaker actually talked about empowerment of, should we say, patients or people living with, which I think is fantastic. But, and a very big but, the message wasn't actually about patient partnership. It was more about understanding what they needed to do or we need to do in order to adhere to instructions given by a medical professional. Again, from a health consumer and, in my case, patient perspective, this isn't good enough. And I look forward to the panel discussion to further discuss this. And the reason it isn't good enough is that self-care requires a collaborative and holistic approach by all involved. This is not from a health consumer perspective that we just want to understand and, why we're doing something. We need to understand and agree that this is something that's good for us. And incentives, don't matter that much in the conventional term. It's about actually finding a personalized pathway, and you as pharmacists can actually be key in that. And another part of that, of course, is health literacy. I agree with those points. And also meaningful access to health data, which, depending on where you are, is quite choppy in different countries today. And it's certainly not harmonized for legislation. In the case of obesity, next slide, please. In the case of obesity, in fact, the only thing which is measured is BMI, which, as we know, in different parts of the world or anywhere, is quite problematic and doesn't actually help us self-manage the disease. So where did I get the word champions from? Because I've just sat there complaining, basically. Next slide, please. Well, what it takes from our perspective is that we absolutely need to walk this path together. We need to be sure, as health consumers, and certainly in my case, people living with obesity, we need to know that actually, as pharmacists, you have self-care embedded in your core educational curricula. It shouldn't be something with learning about self-care along the continuum. And of course, I would say, and please have a special module on self-care and obesity. You need to understand it thoroughly. It shouldn't just be a choice. Secondly, making sure that health consumers like myself and others are actually properly and meaningfully involved in the education experience design. We're not there as recipients, as subjects. We know our bodies. I'll be 50 years old next year. What that means is that if I didn't understand the importance of self-care and how my body reacts to it, I would really have a serious problem by now. I am an expert. People, health consumers are usually experts in their own experience. Use it, partner with it. Then the other element for us, which is really important, is mainstreaming of self-care into policies to remove barriers. So as I mentioned, just in terms of self-medication and complementary treatments, this is not currently included in the vast majority of medical records. It needs to be, because that's where we are. We can't do that unless there is actually a precise policy to enable this. And then again, from an obesity perspective, we are calling for everyone, not least the pharmacists globally, to advocate for obesity national plans like we have for other NCDs, and to include within that self-care elements. This is so, so key. Next slide, please. So, final element, dialogue. But what kind of dialogue are we actually talking about? Next slide, please. For us, it's really important that we have a dialogue with all stakeholders, and especially that as pharmacists, you're able to actually engage in this and champion all of these elements in relation to the 5 A's principle of access to healthcare. So affordability, appropriateness. So not just saying, well, actually, as I've had said to me once, actually, here's some RX vitamin, because RX iron, because you're actually very low on iron and very low on ferritin, but not looking at the appropriateness of the prescription, for instance, from a GP perspective, to note that as a bariatric patient, I can't actually drink orange juice. So prescribing me the cheaper version without vitamin C is not going to be helping my personal health outcomes. What I do notice, and I think that this should be really impressed on pharmacies, is the ability for pharmacists to engage in that conversation with people like me and other health consumers to actually work out, is this actually appropriate? Is this the best thing for you? Because you know us as health consumers a lot better than our GPs and whoever else. Then availability, whether services are even available in the first place. In obesity, no national plan, no harmonization of availability of services, definitely not appropriate services on the whole. Adequately, how sustainable are these services? And accessibility. So are they even available to be used? All of these things, it becomes really, really important to partner up to make sure that community pharmacy services are available and that they are accessible according to the 5 A's principle, and that actually we as health consumers know that you're there, and we know that we can actually have that dialogue with you. Next slide, please. So what can I say? I can't eat ice cream anymore, but I love looking at it. The point is that we need to be able to work together to actually use policy to be able to dispel all of these real world barriers. So I give my take-home messages again. Please do not make assumptions that because something is written down or that the science is there, that actually the narrative or the story is being communicated to health consumers and or policymakers. Do not assume that this is actually embedded already in legislation. We have to work together in order to make this a reality. Building bridges is about equal partnerships. We all have something of value to bring to the table. You are the glue, but we are health consumers and we will go wherever best suits us, much like cats. Dialogue, structured dialogue along the lines of the 5 A's of access to healthcare, and develop allies and champions. You are there to be an amazing ally and also an amazing champion, but so are health consumers, the general public, and people who are already within the system as patients. So on that note, click please, I would like to say thank you very much for your time, and I very much look forward to the ongoing discussion.
Thank you, Jacqueline. And I think you're raising an important point around obesity being listed as a chronic condition. And I think if that can be part of our outcomes as an advocacy role internationally, I think it'll make a huge difference from a funding perspective, because surely chronic diseases fall into the category of compulsory funding. So
yeah, they do. They do, but I have to say there's so much to unpack there, because there's a lot going on at the moment within WHO. There's actually a resolution going through on asking to have the political will to ensure that obesity is formally recognized as a chronic disease. So many of you will have that when you speak with your advocacy contacts. And then the other thing for us within Europe is, at the moment, the European Commission finally said that they would be adopting a roadmap for NCDs along specific disease areas. Needless to say, they're currently ignoring their own definition and categorization. I mean, you know, it's always an issue, and you're quite right. It comes down to the money, but, and a very big but, a lot of the time it's because the payers haven't actually, and the health insurers haven't actually looked at the basic definition of obesity. They're looking at numbers of BMI. They're not looking at how to take a step-by-step approach. And quite frankly, what an absolute golden nugget addressing this through self-management and self-care can help as well.
Thank you for that. We'll take it up further in the panel discussion. I think it's
Thank you.
So our next speaker is Dave Burrows, and Dave is the CEO and CTO of Damiboo in Liverpool, based in the UK. It's a digital technology studio. He specializes in the information management technology for public sector, particularly the UK NHS. An important part of any delivery model, I think, requires this type of technology. So he sits on the Liverpool City Regional Health and Life Science Board. And in 2017, Dave was awarded the NHS Innovation Accelerator Fellowship for an app called Catch, which is Common Approach to Children's Health, which is a self-care information app for new parents. So Dave will probably have a big smile on his face because he belongs to the red side of Merseyside. So welcome, Dave, and the floor is yours. Thank you.
Thank you. Thanks. First slide. Yeah, hi everybody. It's great to be here. Yes, I'm from Damiboo. We're based in Liverpool in the UK, and our greatest exports have been the best band and the best football club in the world. So you can say thanks to me in the chat. So I'm going to do a brief history and generally just have a rundown of our journey and our view of self-care information, a bit about the NHS and how it's changing, because we can't really do anything to do with health in the UK without the NHS, and where we're going. We've been at this for a while. My past life, as was on the website, was computer games industry. I was in there for 20 years. Did very well out of that. But I'm non-clinical. It's only by accident that I sometimes sound like I know what I'm talking about clinically. Digital, and we're concentrating now on digital access to trusted self-care information. So basically, people don't rely on Google and find the scaremongering on there. We are highlighted as good. We're highlighted as good examples and good practice on a few things, and generally try to disrupt quite a bit. Next slide, please. So the outcomes that we try to gain are normally prevention and health literacy in our apps and technology, and appropriate use of health service. And we mean appropriate because obviously in some cases like meningitis and sepsis, we want immediate action. We want people to go to services immediately and use them. And our methods tend to be around the sort of like acknowledgement of comorbidities, and it's not all about clinical and complex reasons. So depression could be about death and stuff like that. And we always work with what's there, and importantly target the person rather than the actual condition. Next slide, please. So where this links into is scope and localization. So the scope is sort of like what information goes in the app. This is what we define as physical and digital lifestyle, work, financial, legal, and things like that. And localization, yeah, is about the where the user is based, and also about the services that are available to them. But we also try to look at the language and the culture, and even how they read the information. So like a website designed for teenagers should be totally different than a website designed for adults or an app designed for adults. So next slide, please. And this can be viewed on a scale with just so like it's easy to visualize and get across. The higher you go on scope, the more you get. And the more to the right you go, the more localization you get. So one app which we're renowned for is Catch, Common Approach to Children's Health. And this started out as a single area, about 250,000 people population, so quite small. And it was concentrated for Liverpool newborns, so shall we say, so self-care information of kids under 5 for new parents. One area, one hospital, one health visitor provider, and also one pathway. Next slide, please. We soon realized that we needed more than digital content. And generally, as we added more non-clinical content, next slide, yeah, that one. It was focusing on prevention and support services. And we ended up with about 450 odd articles and they were coming from 36 external content sources. And about 77 support services, not including just links. These were actual information coming from them. And we had diversity, including things like how to introduce your family dog to a baby, a newborn. And as you can see from the pie graph, the top 3 information sources seen are vaccinations. This was pre-COVID, so we're not really just talking about COVID. Breastfeeding and even play. So it's quite diverse. Next slide. What we then did was we got a few other areas around Liverpool. Liverpool is based on 6 or 7 regions. So 6 of them took us up. So we then sort of started serving to about 1.2 million. I'll get onto sort of like the user base, but that's the population of the area. And 6 areas, there's a lot of people and a lot of hospitals and a lot of health providers and a lot of people. Next slide. And also what we saw is as the areas we took up grew, there was increased variation. I expected increased variation in support services because there's different charities and different local charities. But what we didn't appreciate was there was slight variations in the UK pathways. Even though they were supposed to be national, they weren't. They were slightly based on the demographics. For instance, one area had a demographic which was quite old. So like some of the services for the younger new parents were, I wouldn't say downgraded, but slightly less important. But what did come clear through us scaling this intervention was the importance of all health visitors. And by that, I mean anybody to do with health pharmacies and everything. And their support required for the brand and knowing that all the information in their version of Catch was customized for their location and produced by people. And generally it became quite evident when we did one of our feedback survey forms, when a staff member said that she had actually stopped referring people to the national information source because she knew some things on there were wrong for their region. Just in days and weeks and things like that, and particularly health visitor timings and stuff. But she wasn't too sure, so she's just stopped referring people to it. So it's very important to get health visitors involved. Next slide. And this whole thing, we sort of like come under the banner of what we call ownership of the project or ownership of the brand. This knowledge that whatever we produce is customized to a very small user group, i.e. localized to a very small user group. Next slide. But of course, it's harder to do this. And, you know, there's a nice line, or we'd hope that there's a nice line between doing something easy for a very, very small clinical, highly relevant small condition and doing it in a town or a small region. And it wouldn't be nice if it was sort of like slightly harder to spread that out and do a generic one. But what we saw, next slide, please, was that the complexity gets very, very complex very quickly. So if you wanted to do a system that had every scope possible clinically and self-care and whatever, then that would be fairly complex. But then if you start to then say, right, we want to localize that and make it relevant to every location, maybe down to a population size of 50,000, and the cultures which are involved in that population size, and the languages, and also the different designs and mobile apps and stuff like that go in there, it gets very, very complex very, very quickly, and obviously costly as well. So that's where we were sitting with Catch. Next slide, please. To talk a bit about system readiness and where we're up to with the NHS, is that the NHS is a brand for a start. So it's not a single organisation. There's a certain amount of accountability, but it's run by several organisations and trusts, mostly non-for-profit, but it's a brand really, anything else. And it's extremely good at emergencies, and obviously with COVID, it's very good with vaccinations, and also very good with long-term care. So if you break your leg, that's fine. And also what's good about it is accountancy. All the accountancy within the NHS is set for an event to happen to a person. So, putting a plaster cast on a person's leg once they've broken it, we can account for that to that person, and it costs whatever, £100, and that will build for, through the system. What it's very bad at is prevention, namely because how do you sort of like track prevention? How do you say, well, we did something to stop people breaking their legs, and therefore it saved us £100, because it's very hard to track people on non-events, so to speak. Next slide, please. However, this has been changing, and it started to change in 2018, 2017, 2018, with plans around integrated care systems and what's called sustainability plans. And the first systems came out in 2019, where councils and local NHS were already working together, like some parts in London and some parts in Greater Manchester were already officially named that. But COVID stopped all that, and basically they're all moving to what's called integrated care systems April next year. And the concentration on integrated care systems is targeting population health and working together, and very much this idea that making every contact count. Next slide, please. And this is something that Catch is very aware of. It's a brand. This sort of like making every contact count is something that we support, and it's designed for that. So although Catch covers a population area, or the sort of like the 6 or 7 areas of Catch that we cover, each area has a population size of 250,000. It's really got a user base of around 7 to 10,000. We have a birth rate of about 1%, and then you have sort of like families having multiple kids at the same time. So it's about 7 to 10,000. So it's quite small. So even with 6 areas where your user base in each area is 7 to 10,000, and you're wanting to try to do an element of localization, it's still very complex. Next slide, please. So we decided that if we were to do it bigger and go up that graph and do all scope and all localization, then we needed to sort of like design something better. So we did that. And generally, instead of creating an intervention to the public, what we thought was we'd create an intervention to the professionals and the people that are public facing. So what we've developed, which is pretty much based off Catch, is this idea of download feeds. It's an ownership that people can own, but the idea is not a single website. It's a syndication platform, and the idea is to manage and deliver trusted information to any digital endpoint, which could be a primary school, a primary like GP websites, secondary hospital, a charity, pharmacy websites. So any digital endpoint that is in a region could use this resource to show self-care information and sort it and filter it as per their need and want. Next slide, please. And it's fairly technical. I wasn't going to go into it, but we came up with these sort of like 6 things that we wanted to do. It was going to be attributed, so people could tell where the information was from. Our main concern was no duplication, so people wouldn't have to cut and paste all the time and therefore lose the attribution. You could aggregate content together. Control would remain where control should remain. So if you didn't want our content on your website, you could remove it. If a source wanted to remove some content, it would remove it from the whole system. And generally, there was also an element of analytics in there as well that is totally anonymous, for GDPR reasons. Next slide, please. And the final slides, and this is where we're up to at the moment. So at the moment, through feeds, we manage around 80 primary care websites. We're already commissioned for a further 70. We're chatting, it looks like we're going to be managing pretty much all the self-care information for all of the region within our region. So that's about 2.8 million in the population size. And what that allows people to do is to sort of like have a flow down of information and to manage the localization in each of these regions. So as the information flows down, you can add local support cost or you can remove stuff, but and it also delivers it to any digital outlet going, basically. So we're very hopeful for the future. And yeah, great. Next slide. Thank you.
Thanks so much for that, Dave. Let's move on to the panel discussion. And I'm going to invite all of the speakers to put on their videos, and you can come off mute when you ask the question. Before we get to the questions itself, I just wanted to remind our audience that certificates will be issued for attendance at the end of it. And if you have any more questions, please put it in the Q&A. So let's move on then to the first question that has been raised. And this comes from Usama, who wants to know, what is the main reason for obesity in Belgium? And I think this is probably something that we could discuss across the panel, because the reasoning in India might be different from in the UK versus Belgium or in Africa, for example. So I'm going to open this up and start with Jacqueline, because the question is from Belgium. Thank you.
Yeah. Okay, wonderful. So I'm actually going to open it up slightly, actually globally, because what a lot of people don't realize, and I think this is a great question, Usama, what a lot of people don't realize is that by the time you see the weight, actually the disease progression is quite far down the road. So with adult obesity, I'm not talking about adolescent or pediatric obesity, but with adult obesity, there are actually more or less 6 buckets of biological causes of the onset of obesity. One of which is where I came in, is endocrine disorders. Another one is actually psychological. So we're talking depression, clinical depression before which triggers onset of obesity. Another one is actually a quite interesting list of medications, mostly about epilepsy, psychotics, all of these sorts of things. Another element could be your sleep cycle. So what people like to call lifestyle, but it's actually how you live your life that gets disrupted that affects your biology. Then another one could be actually after surgery as well. Various types of surgery are highly likely to cause onset of the biology of obesity. And I always forget the last one, but there are 6. So basically what we're faced with is that you have this, should we say, disruption of your biological system that stops your brain through your leptin receptors, basically stops your brain from receiving that stop message. So it kind of becomes foggy. You end up with a lot of inflammation, and then the whole cycle starts. You suddenly start feeling hungry. You start to notice the pounds on the scale, which will be inflammation as well as less muscle mass, because the definition of obesity globally is abnormal and or excessive fat accumulation that leads to ill health. So this is about your body composition and how, shall we say, your environment, once the biology has been triggered, to go back to Sham's point, it then depends on your physical environment, but how that physical environment interacts with your biology, and what are the mitigations that you can take to stop the disease progression. So in Belgium terms, and I would say everywhere, this is mostly about lack of understanding, lack of actually even being diagnosed properly, because on the whole, it's all about BMI. So me as somebody, who's lived in 4 different countries, of an ethnic minority within Europe, the European context, when someone measures my BMI, actually my disease progression is going to manifest itself differently in terms of being measured compared to somebody white Western European man. So essentially I would say that the main reason why we've got an epidemic going on for obesity is lack of catching it earlier, lack of associating the biology with the exacerbating environmental factors, and quite frankly, denial of the various powers that be to start doing something concretely about it, which is evidence-based. Because telling me to eat less and move more, A, is disrespectful to the science, and B, quite frankly, is disrespectful to me.
Thank you very much. Let me move then to Prof. Reddy in India and see if he wants to add to that conversation.
Well, let me start off with the last comment that Jacqueline made. There was no intent in being disrespectful when you're advocating diet and physical activity as a matter of health promotion. We're not talking only about obesity, talking about a lot of other disorders, including diabetes and metabolic syndrome. And we recognize that there have been a variety of diabetes prevention trials globally, United States, Finland, China, India, which have shown anywhere between 29% to 58% reduction in the incidence of diabetes in persons with pre-diabetes with these regimens, and the National Institutes of Health in the USA actually adopted as a part of their treatment. So we're not talking only about bariatric surgery here. And what we eat is what part of our diet, whether it's protein or water. So that's all part of our diet. But now coming to the question of where diabetes comes in, where obesity comes in India, I entirely agree with Jacqueline there, that there are multiple metabolic conditions which need to be considered and are not necessarily assessed by body mass index. We know that it's the total body fat content, the nature of body fat, as well as the distribution of body fat that matters. So in India, it so happens that there are multiple factors that have been contributing. One is even undernutrition in pregnancy of the mother and of the child in early childhood actually causes what is called epigenetic programming, in which the gene expression is altered, and ultimately you land up with more of abdominal body fat, even if your overall BMI is not high. Your total body fat content increases at the expense of the muscle mass. Your lean muscle mass decreases, and therefore your muscle also becomes more insulin resistant and therefore more likely to develop diabetes. Now, therefore, this is a metabolic obesity, where even if you're not considered obese by your BMI standards, you're still manifesting diabetes, glucose intolerance, the abnormal blood lipids, and possible tendency towards coronary heart disease because of that reason. So we have 30% of diabetes in India as thin diabetes. So, but that is because of metabolic obesity or increased body adiposity, particularly abdominal adiposity. But there are also reasons why the nature of changed diets with a lot of ultra-processed foods, of course, excessive consumption of refined carbohydrates and decreasing physical activity are also driving the pandemic. It's not as though we have not seen changes happening in 30, 40 years because of the changed dietary habits, where there has been a considerable push towards some of these products. And we see, therefore, some of the alterations in diet, and therefore the increase in obesity, in childhood obesity, as well as adolescent obesity, is a marketed malady and an advertised addiction of the nature of energy-dense but nutrient-poor foods. We also know that there are body changes that occur because of air pollution. Air pollution also causes certain epigenetic changes, and that also increases the tendency towards the inflammation and diabetes. We also know that the nature of food that we consume, particularly if it is low in soluble fiber and insoluble fiber as well, but is rich in ultra-processed foods, is also going to change the nature of the bacterial flora in our gut, what's called the microbiome. And the microbiome matters a lot for metabolic control. The bacteria in our gut not only modulate our immunity and our metabolism, but also send signals to the brain. And therefore, whether it's the leptin or the ghrelin, their secretion is also modulated by what your microbiome eats. Therefore, the nature of diet matters too there. So there are multiple conditions that are driving the overall obesity epidemic in India, partly because of developmental origins or because of undernutrition in pregnancy and early childhood, reflected later on in abdominal adiposity, but also changed nature of the food products, changed patterns of diet, and decreasing physical activity, multiple factors combining to drive this epidemic.
Thanks so much, Prof.
Can I just jump in really quickly and say thank you, Srinath. Music to my ears. One slight caveat there is that the other thing that I think is very confusing, certainly for policymakers, is the differentiation, which actually you caught really well, the differentiation between onset, so what actually triggered the onset of the obesity, and then the disease progression, because with other chronic diseases, that's how we express. But in the past, I would say policymakers and certainly medical professionals at the moment don't explain that to us at all. So I'd like to thank you so much, and also remind everybody that actually by treating obesity as early as possible, we can actually prevent 80% of type 2 diabetes and 20% of adult preventable cancers. So these things are not going on in isolation. And I really feel that if we took a more holistic approach, very much including the self-care continuum included in all of that, we would actually be able to make a dent in, as you quite rightly said, in my layman's terms, the next generation, by making sure that parents, shall we say, both men and women, are treated for obesity. And that would mean that the predisposition of children developing early onset childhood obesity would go down from that 70% down to 30% again. So it's very much, I'm not going to say it's easy, but to actually break it down and the way that you just described, I'm so grateful to have heard that.
Thank you, Jacqueline. Let me move on to another question, and I'm going to phase this to Dave. Dave, Donna McCoy wants to know, please give an example of an NHS policy that would not be relevant to a particular local region.
It's so maybe I said it quite a bit wrong. Was so it wouldn't be that the case in point that we had wasn't that the policy wasn't relevant. It was that the national guidelines weren't exactly, I wouldn't say what was followed locally. And it was the one which was pointed out to me was a couple of years ago by a health visitor, where the national guidelines for health visits of new babies after 8 weeks was something like, you know, I'm not, as I said, I'm not professional, so like a 3 months, and certainly within the UK, within England, they're specified, but they're slightly different in Scotland and Ireland, and Northern Ireland and Wales. But the UK one was like after 8 weeks, it was like 3 months and then 6 months. But for this particular region, they had got the okay to do it at 2 and 4 and 6 or something like that. So I think they were doing more than there was required. But the example wasn't so much that the information was wrong. The example I was trying to get across was that it was something as simple as that through this professional's ability to trust the national information, because she basically said, right, well, if we're doing something wrong like that, and I'm getting people saying, well, you know, you should be coming at this time because that's what national is, and I'm having these conversations as such a tiny change, then what else is wrong on there? It sounds a bit weird, but I can't explain what, you know, that's what she was concerned about. So the fact that she knew on catch that it had been checked by her local region and it was perfect, basically, gave her more confidence than the national version.
Thank you, Dave. Let me just stay on the issue of technology. We don't have another question on that, but let me pose this question to all three speakers again. So we're looking at self-care, and in order to move it from where it is currently, I think the important issue is having technology. Two is the issue of communicating information to users of self-care so that they become more knowledgeable. So let me open up those issues of technology and communication and start with Prof. Reddy, if you can just give us some comment on that.
I think technology is absolutely important, and having digital literacy is going to be absolutely critical. I think a great deal is being done even during the COVID pandemic through telehealth services, for example. It is almost always that it's a physician guiding initially in the patient choices in terms of the treatment paths to follow. But even otherwise, for self-directed search of what would be appropriate, and also to understand more about the medication, about the side effects, about the need for adherence, and when to seek additional care, all of that is now so digitally dependent that digital literacy becomes absolutely important. And I think that is where one of the challenges is going to lie, in the digital divide, both across countries and within countries. And I think if we can make it as simplified as possible, and at least to some extent language neutral and icon based, I think that will also be very, very helpful. But I think the availability of digital health services have greatly enhanced people's ability for self-care.
Thanks, Prof. Jacqueline, you want to make a comment on that?
Yes, I have plenty. Okay, so yeah, I always do. It's really tough to stop me on these things. Okay, so for digital, there are two things. Completely agree, as Prof. Reddy mentioned, about digital health literacy. However, because there always is, the issue that we're absolutely facing in Belgium, and not just within the obesity community, but everywhere, is, you know, as I mentioned in my slides, there's a big difference between what's written on paper, even legislation in Belgium, and what the reality is. So case in point, we all supposedly have our electronic health record, and that it's meant to be really easy for us to access all of the points. However, the reality is that when we go and go to see our doctors, want to get blood tests, want to actually see what the prescriptions and or complementary, so self-care elements are there, it's not a given. The kine, so the physiotherapist information, not put on our patient records. Any outsourced, should we say, tertiary care, not automatically put onto our electronic patient records. So what that means is that on paper, it all looks really good. The reality is that for co-decision, clinical co-decision making, we don't have the full story. And actually, as patients, we also have to remember to specifically ask to get a copy of our various elements. And this isn't just Belgium, it's across Europe. So for me, it's very much a case of not only patient literacy, digital health literacy, but for everybody. And very much as well for the professionals, so obviously including community pharmacists, for healthcare professionals to stand up and say, we want to make sure that we have proper access to the full file, so that when we're discussing with when people come into the pharmacy for both RX and other, that we can actually have a real and informed discussion with them. And that's just for, shall we say, primary use of data. For secondary use of data, it's a mess. Because again, certainly within the obesity community, we struggle to have proper surveillance data collected beyond BMI. So we're not actually getting a full picture. And for the national health surveys as well, not least in Belgium, the information isn't actually accurate. So I would say, it needs an overhaul. And also, most importantly, for me, it's not just about simplification, because we got to eat less and move more through simplification. What we actually need is precision and accuracy, so that everybody is actually speaking the same language, which is what Prof. Reddy did mention. But it's really important that, say, for instance, when I read my medical record in whichever language, because I've got three I can read in, but if I'm reading my medical record, that actually everything is there, and that I can then have a proper conversation and make informed choices for my self-management and self-care as well.
Thank you very much. Dave, I'm going to let you conclude on the issue of digital.
For me, yeah, obviously we go, obviously I'm for digital. I've been all my life. So that's not going to come as any surprise. The digital divide comes up quite a lot, and I can only talk to the UK and the NHS, but the NHS has been around for 72 years now, and is built around non-digital. So the default is non-digital at the moment. So what we're really doing isn't sort of like, what we're doing is getting people who want to do it digitally away from that thing, so away from the non-digital engagement that they could do, and therefore releasing up opportunities for the people who can't do digital to have the non-digital engagement. So that's particularly important. The other thing that digital does, and what we're trying to do is, by organizing information, is also put the right information into professionals' hands. So even when you go to an engagement with a professional, you're probably going to go for a particular reason, say GP or cancer or whatever like that. And if you talk to them about a non-expert case, then they might not know the answer. They'll know more than a layman, but they might not know what support's available and stuff like that. So in us creating these common systems that can be used anywhere, and a common approach to healthcare, basically, healthcare information, it also can be accessed by the professionals that can then deal with non-digital engagements. We have the same issues with patient records. They're all over the place in our country. We've tried to do numerous systems where it's a national system, and they haven't worked. And yeah, I do foresee in the future there's going to be a time when and it should be now, where the patient has far more information, far more digital information and stats on what they've been doing and how their health is going than the professionals do. And yeah, there's numerous platforms that aim to put the onus on the sort of like the citizen to own the patient record, rather than several trusts and several organizations to own it instead.
Thanks, Dave. We've almost come to the end. We've got about 6 minutes. So if we can go on to the next slide, which is the wrap up and conclusion. What I'm going to do here is allow the panelists 1 minute each just to summarize the issue of universal health coverage from the perspective of self-care, and maybe one-liner on what pharmacy can do to contribute to this. So let me start with Prof. Reddy. Prof. Reddy, I think you're muted.
Thank you. In the era of universal health coverage, self-care will certainly bridge the gaps in access. It will certainly help to bridge the gaps in quality of care. It will set the right kind of demand for services and ensure that the supply is steered in the appropriate direction. And it will also bring in quality monitors along the way. And therefore, ultimately also, by reducing the amount of disease severity, morbidity, as well as the complications of neglected disease or even of poor quality medication, reduce the overall costs of care to the individual as well as to society. So ultimately, it will enhance even a better utilization of the funds that are available in society for health services.
Thanks, Prof. Reddy. I couldn't have summarized that better. Jacqueline, your 1 minute. You muted, Jacqueline.
I'm going to build on Prof. Reddy's extremely good summary and make a call for pharmacists, community pharmacists, to work on having self-care along the continuum included within national chronic disease plans. It is the way forward with health consumers / patients, public, as engaged equal partners to develop those plans.
Thank you, Jacqueline. I'm sure Christopher and Mila that's on the call are taking notes. Over to you, Dave.
It's very hard to follow all that. As far as the NHS, in the NHS point of view, the UK's point of view, we have a universal illness coverage at the moment. I think to do universal health coverage, I think we need to go down the self-care road.
Thank you, Dave. So we come to the end of that session. Before we do, if we can move on to the next, I just want to remind you that the next event is on the 16th of December at the same time, 11 to 12:30 CET, which is supporting self-care, and we're going to focus on sexual health there. Next one. So if you want to go back and check on other digital events, you can go onto the FIP website and look for events.fip.org. Next slide. So again, let us say a huge thank you to Ricket for their ongoing support on this self-care project. Without that contribution, we certainly would not have been able to put these amazing conferences together over the last year. Last slide. So all that's left for me now, we've got literally a minute, is to say a very special thank you to my brilliant panelists today. And I think you've done an exceptional job. I'm sure that the FIP would take notes from this and ensure that it is in our next policy document. I believe there is a policy document already that's on the table. And to everyone that has attended today, thank you very much for your attendance. We'll see you at the next digital conference. And then to my super team that have helped me to put this together and allowed this to happen so easily. Thank you very much. I'll see you at the next conference. Take care, everyone, and good luck. Have a good day.
Thank you.